Hello everyone, I'm Jared Dashevsky, founder, creator of Healthcare Huddle. If you're watching this video, I assume you're in the middle of reading my Inefficiency Insights article about how I'm using generative AI tools like Doximity to improve patient care, making sure I'm not missing anything in my assessment and plan that would have otherwise caused, patient harm in the long run. And I've been using this process for the past couple of months, mainly for complex patients or for presentations that I'm not too familiar with. I haven't really gotten all my reps in, or not your bread and butter presentations. So here's an example for a patient. I added some details. A patient I saw several months ago. I de-identified everything. But just to walk you through the process that I'm using right now is that I will see the patient, obviously, write the whole H&P and do my own assessment and plan. But just to walk you through my reasoning, 70-year-old male with type 2 diabetes, some generalized anxiety disorder, depression, fibromyalgia, lumbar radiculopathy, smoking history. I saw him several months ago, initially for generalized body aches, diagnosed them with depression. They didn't want any medication. And then he's presenting with several falls within the past 2 months, which is out of the ordinary for them. So basically said he just fell twice out of nowhere, didn't hit his head, wasn't falling towards one side. Said they have a new headache specifically behind the eye. I'm not sure if it was the right eye or left eye, but this headache lasts all day. It has visual changes like aura, involved with, I think, maybe ibuprofen. New headache though, worse with straining, worse in the morning, chronic vision changes, feels like the legs are giving out, and then feels like the legs are too weak, so that when they fall they have trouble getting up. Also endorsing some cognition issues like memory stuff. They received B12 shots a couple months ago, back in November, I guess, but no weight loss. And I believe this visit was telehealth, so there was no actual vitals, but from what I gathered, overall well appearing, and then the neuro exam was largely unremarkable. So I took a step back and tried to think what was going on. And if you're not in medicine, red flag is a headache, especially after 50. New headaches after 50, not normal. And you're definitely concerned for like some mass in the brain. So here is my differential: subacute headache, recurrent falls, red flag features, new progressive headache, Valsalva, like with straining, concerning for increased intracranial pressure. And this includes a mass versus hydrocephalus. The patient does have radiculopathy, but just want to explain the headache. I talked about risk of stroke, but then also mentioned, it was telehealth, so can't really do much. And then here was my plan. And then they had shoulder pain as well from the fall, so I just said, we'll just get an x-ray. Didn't really think too much of the H&P, of the differential for that. And then some return precautions. And so this RX was for the MRI brain with and without contrast. So what I'll do is I'll copy this entire H&P, throw into Doximity so it can properly evaluate my plan using the prompt that I included in Inefficiency Insights. And then it will output, well, let's see what it outputs. Comparing evidence, blah, 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 blah. High-risk neurologic presentation. Correctly red flagged, right? New headache. No bueno. Good. Avoided anchoring on the lumbar radiculopathy. Good job, Jared. ED precautions. Differential, it's telling me it could be stronger with like the subdural hematoma. Oh, right. Chronic subdural hematoma, even without head strike. Often unwitnessed or forgotten. The patient had memory problems. That's great. Giant cell arteritis. Fantastic. 70-year-old. I didn't really ask about jaw claudication, but they didn't have scalp tenderness, that's for sure. So low suspicion, but you don't want to miss it. The migraine with aura, sure, it could definitely happen, but it would be rare to have migraines for the first time at 70. And then working further through this like mechanical fall. And then the cognitive changes workup, they'll definitely need a reassessment for cognition. Left shoulder pain reasonable and appropriate. Great. What would make this excellent? All of those. But again, this was telehealth. So let's see. Fall evaluation, C+. Damn it. Okay. But anyway, so I'll show you what I used this for this particular patient a couple months ago, and my updated H&P did include, let's see, chronic subdural hematoma, right? Because it told me to mention that, and then giant cell arteritis, but lower suspicion, and then I ordered ESR CRP because this happened months ago. They weren't, they were done. Ischemic stroke I talked about, and then it actually did tell me to include the differential last time, but now it said it was good. Whatever, I included it anyway for the shoulder pain, and that's that. So I ended up adding on ESR CRP, which turned out to be negative, so it wasn't too much of an issue. But again, this helped me learn a little bit about what not to miss, and it helped identify gaps. So by the time I created or discussed with the patient after talking with the attending, we already had this plan, and I think it helped patient care. So consider trying this with your patients.